Good afternoon. My name is Alexandra Espinel, and I'm a pediatric otolaryngologist at Children's National Medical Center in Washington, D.C. Thank you very much for having me here today, and we'll be talking about updates on middle ear pathology. So some learning objectives for after this 20-minute talk. By the end of the talk, I hope you can recognize the guidelines for management of otitis media with effusion, and then apply these concepts of management to pediatric patients with otitis media with effusion. So 90% of children have otitis media with effusion, and on average, develop 4 episodes a year. We see even more of this in children with developmental difficulties, and it's also more problematic and burdensome for these children. In the United States, we see about 2.2 million new cases diagnosed each year, and it is the most common cause of hearing impairment in developed patients. It's important because this is a treatable cause of hearing loss. Direct costs related to otitis media in the United States is about $5 billion annually. And, it can really have a substantial quality of life impact for children and their caregiver, with a lot of associated symptoms that can really also affect the child and their caregiver. So otitis media with effusion it is a problem that we see in kids differentiated between acute otitis media, in that otitis media with effusion is serous treated fluid, so non-infected fluid, could also be mucoid fluid that gets stuck here in the middle ear. As opposed to acute otitis media is purulent fluid or pus that gets stuck here in the middle ear and causes symptoms such as pain and fever. And a child who's treated for acute otitis media, taking antibiotics may turn this purulent fluid into non-purulent fluid. However, the fluid persists, and the fluid persisting can then predispose them to further infections. This is because in children, the eustachian tube is shorter, more horizontal, and more floppy than in the adult. So it's less able to regulate the pressure of the middle ear. With that inability to regulate the pressure of the middle ear, this fluid can come and then get stuck there. Evaluation is first based off of pneumatic otoscopy. And these are guidelines based on a published guideline from the American Academy of Otolaryngology that was most recently updated in 2016. This included data from 13 clinical practice guidelines, 20 systematic reviews, and 49 randomized controlled trials to come up with these guidelines to help guide the management of otitis media with effusion. So pneumatic otoscopy is utilized in the office where a seal is formed between the otoscope and the external auditory canal. When this pressure is applied, we can see motion of the eardrum. And this motion of the eardrum is a good indicator of a healthy middle ear and a healthy eardrum. And this, a mobile eardrum would then indicate a normal ear, whereas an immobile eardrum signifies that there's a problem with either the middle ear, the tympanic membrane, or both. It's recommended to be used to document a middle ear infusion when diagnosing otitis media with effusion in a child. Also, it can be used to assess for otitis media in children who have otalgia, hearing loss, or both. Tympanometry, which is an audiologic assessment, is used when pneumatic otoscopy is uncertain. In the United States, this can be done in many pediatricians' office. It's also part of our standard audiogram. In this case, a normal mobile audiogram will have a type A tympanogram, in which around a pressure of 0, we'll see a peak, which shows the movement of the eardrum. In this figure here, this one in the middle shows a normal tympanogram, where the one that peaks shows a very mobile eardrum, whereas the one down shows a decreased mobile eardrum. Over here on the left, we see these flat tracings. These flat tracings are considered type B tympanograms or flat tympanograms, which are signs of decreased eardrum movement, which could be an indicator of middle ear disease, whether it's middle ear effusion, tympanic membrane problem, or issues with the ossicles. At-risk children should be evaluated for otitis media with effusion at the time of their diagnosis of these risk factors, as well as, again, age 12 to 18 months. These at-risk children, you can see are listed above, but they're children with communication issues such as blindness or developmental delay. Also, syndromic children or craniofacial children, and kids with other hearing loss need to be screened for this. If on screening otitis media with effusion is identified, a hearing test is then recommended to establish baseline hearing to allow the otitis media with effusion to be tracked and monitored. Healthy children, they do not need to be screened for otitis media with effusion unless they have symptoms that may be attributed to otitis media with effusion. These symptoms, of course, include otalgia and hearing loss, but also include issues with balance, poor school performance, behavioral problems, and other sources of ear discomfort. In these children, they should also be screened for otitis media with effusion, first by pneumatic otoscopy and then tympanometry if needed. So when do we treat otitis media with effusion? So in children that are not at risk, we can wait for 3 months. So for example, a child has an incidental finding of a middle ear effusion, has no symptoms. The recommendation would be to come back in 3 months to assess if that effusion is still persistent. The literature does not support using oral steroids or nasal steroids, antibiotics, or antihistamines to help clear this effusion faster and prevent need for further intervention. This effusion should then be reevaluated at anywhere between 3 and 6 months, or until the effusion has cleared or hearing loss is documented. If otitis media is present again at 3 months, a full audiogram is recommended. And you can see here, this is a conductive hearing loss, which is related to a middle ear effusion. So as you can see, our hearing is about 50 decibels, whereas normally would be between 0 and 10. So this 40 decibel gap is due to the middle ear fluid. And by treating this middle ear fluid, we would then be able to bring this hearing up to normal. So the surgical indications for tympanostomy tubes were reviewed in a recent guideline published by the American Academy of Otolaryngology that was just updated in 2022. Tympanostomy tubes is the most common ambulatory surgery performed in children in the United States. And most children have had at least one episode of acute otitis media with effusion by 3 years old, and by 6 years, about half of the children in the United States have had 3 or more infections. At any given time, about 20% of young school-aged children have middle ear effusion, with nearly all school-aged children experiencing this once during their life. In a study of the National Health Interview Survey data from 2014, 8.6% of children under the age 18 had prior tympanostomy tubes. The annual health cost is almost $2 billion per year for children in the United States at an average cost of about $2,700 per procedure. So, it's important to see, to make sure we're doing this for the right children when they need it, when they're really going to benefit from it. And also, too, can help reduce some of that healthcare burden to avoid unnecessary procedures in children who don't need it. As you can see here, there's two main types of tympanostomy tubes. There are the short-acting grommets type tubes that last on average about 15 months. And there are longer-acting T-type tubes, which are indicated for kids with more severe middle ear disease, multiple sets of ear tubes, and these last for about 3 years. Surgical indications, they're indicated for children with chronic otitis media with effusion, which, as we previously defined, as otitis media effusion that's been persistent for more than 3 months with associated hearing difficulty, balance problems, poor school performance, behavioral problems, ear discomfort, or reduced quality of life. In children who are having recurrent ear infections, and we define recurrent ear infections as more than 3 ear infections in 4 months, more than 4 ear infections in 6 months. Also have to have a middle ear effusion at the time of evaluation for tympanostomy tubes. So, for example, if a child reports having 6 episodes of otitis media in the last 3 months, however, at the time of evaluation does not have middle ear effusions, it is recommended that ear tubes be deferred, as the clear middle ear indicates an improvement of eustachian tube dysfunction. We do not need to do the procedure. Benefits of the tympanostomy tube in children with acute otitis media. First, without a tube, the etiology is pretty severe. Children who have otitis media with a tube really don't have any pain. They're pretty much asymptomatic other than the otorrhea, which we'll talk about in a few minutes. There's no persistent middle ear effusion after the infection because this tube, as you can see in this bottom picture here, is draining that fluid. Children with tubes do not need oral antibiotics, and oral or topical antibiotic ear drops are our first line treatments. Also, to the risks of complications such as intracranial complications are extremely rare because this fluid is going out through the tube rather than eating through the bone towards the skull base. So in general, while children will still get acute otitis media while they have ear tubes, it will be much less symptomatic as these tubes are treating all the symptoms, namely fever, pain, and hearing loss because this fluid is not allowed to build up and stay. In some children, it is recommended that they have an adenoidectomy at the same time as their tympanostomy tubes. This is because, as you can see here, the adenoid sits in the back of the nasopharynx, adjacent to the eustachian tube opening. In children with large adenoids, the adenoid physically blocks the eustachian tube opening and passage of air through the eustachian tube to regulate that pressure in the middle ear. Also, it is thought that bacteria from the adenoids can contribute to chronic inflammation of the middle ear space by causing inflammation of the eustachian tube. For children who are 4 years and older and need multiple sets of ear tubes, so greater than 1, adenoidectomy is recommended at the same time as the ear tubes. In children younger than 4 that do not have symptoms directly related to the adenoids, adjuvant adenoidectomy is not indicated. And these symptoms would be chronic nasal congestion, snoring, chronic rhinorrhea, and also recurrent sinusitis, and that would lead to adenoidectomy indicated. There is evidence to suggest that adenoidectomy at the time of tympanostomy tube placement reduces the need for further sets of tympanostomy tubes to be placed after the tubes extrude. Postoperative care, as mentioned in the previous slide, and you can see here a tube with some fluid, some purulent fluid draining out of it. And here's a tube with some bloody fluid draining out of it. Can be treated with topical antibiotic ear drops. That's because the tube allows a connection between the external auditory canal and the middle ear space, and drops are able to go through the tube to treat the inflamed tissue of the middle ear mucosa that is causing the otorrhea. Oral antibiotics are not needed because we're allowed to have this topical treatment. As such, antibiotic resistance is not seen because we're not doing systemic therapy. Historically, children with ear tubes have been recommended to wear earplugs to prevent water from getting in the ears, thinking that that would cause irritation in the ear and area. However, recent guidelines do not align with this, and no prophylactic water precautions are needed for children with ear tubes. Therefore, they can go about their normal lives, swimming and bathing. It is recommended that children with tympanostomy tubes be seen within 3 months of a tube placement. And at that time, if there's a preoperative abnormal audiogram, an audiogram is recommended. They then should be followed routinely until the tubes extrude. So that is the end of my talk. I thank you for your time and hope that this information can help guide you in management